Hello, my name is Dr. Hans Sperling, and I want to talk to you today about guided approach to the full art rehabilitation. My personal philosophy in dentistry is to make things as simple, efficient, and cost-effective as possible. This presentation was given at the Academy of General Dentistry at the annual meeting in Minneapolis in July of 2024. I don't have any commercial biases, and the objectives of this presentation is to understand the steps needed to perform a fully digital, fully guided approach to the full arch rehabilitation for a terminal dentition patient. For an already edentulous patient, it's a little bit different. Understand the records needed for a digital approach to full arch rehabilitation and how to obtain them. Be able to establish protocols that will simplify the process of a full arch treatment, and to be able to reduce the number of appointments needed to deliver an outstanding final prosthesis. We're all too familiar with the life cycle of a tooth, and we know that we start with the dental sealant, maybe an interproximal caries, we replace the filling, an indirect restoration, ending up in a root canal, then we end up with dental implants. Terminal dentition is a situation where the teeth are at the end of their lifespan. Terminal dentition refers to the point in time where a person's own remaining teeth will have to be removed and replaced by something new. It is a rather subjective term depending on each dentist's philosophy of treatment. Some people would like to keep the teeth as much as possible. Other people rather conserve the bone. Other people would restore them in different ways. So this is definitely something that has to be considered with the restorative needs of the patient, the overall health of the patient, the wants and desires of the patient, and the philosophies of the treating dentist. Terminal dentition takes years to come about. It's usually not coming about from one moment to the next. And some of the causes are poor oral hygiene, dry mouth, gum disease, failing restorations, tooth decay and trauma, tooth wear, systemic diseases, prior tooth loss, drug addiction, and we have to consider restorability of the teeth and patient's expectations. But as a general rule, dental implants as a prosthodontic rehabilitation for missing teeth have a predictable prognosis with minimal biological trauma at a reasonable cost. More than knowing exactly the step-by-step, I would like people to get away with this knowing the philosophy and understanding the way of thinking. If you understand the process, then it's easier to follow the protocols and the procedures. So the step one is to begin with good facial pictures showing a big smile of the patient. So very often patients that are not comfortable with their teeth will show a smile that is not a full smile. In this case, the patient, we asked them to smile and they gave us eyes but no teeth. So I told her, okay, show me teeth. And then she showed teeth but not eyes. And then I said, show me eyes and teeth. And this is what we got. So taking good facial pictures may require a little bit of production. Patients often take a long time until they get comfortable with their smile and they're able to smile naturally and comfortably. This patient, who's the same as the previous pictures, took 2.5 years to show us a nice, beautiful smile after we had restored her mouth. Now, very often we tell the patient smile, and this is what we get. A partial smile of the patient, mostly displaying some teeth. Of course, this patient has many reasons not to show her smile, but if we delegate this to the assistant and she comes in and says, doctor, this is as big as it gets, then you're in for a treat, because then when we tell the patient, okay, give me a big smile, now we're having some display of the gum, right? The gingival tissues, the lip raises up more. And my favorite line to tell the patient is show me gums, because you never know how much a patient's going to show their lip and raise their lip until you tell them show me gums. And the problem is that this is a completely different treatment regarding uh, if the patient shows the smile on the left side, it would be an FP1 type of prosthesis, restoring only teeth. Whereas on the right side, it would take considerably bone reduction to be able to give the patient a nice smile, to hide that margin of the crown. So we got to start with the proper diagnosis and proper treatment planning, and nothing for me is more important than a big, full smile. Maybe videos of the patient showing the lip in motion, telling the patient a pair of good jokes, and then seeing how they react. Now, when a patient does not show a full smile, well, then the treatment plan is rather simple, right? But we also have to be aware of asymmetries that may happen in the patient and how we're going to compensate for this. So evaluation of good facial pictures, patients out of the chair. Very often I see these pictures taken chair side and the patient's head to one side or the other. Really, we need to see the patient straight on, showing a full smile. I also would like to see good clinical photographs. There's a lot of information that we gather from photographs that we not gather from x-rays or from scans of the patient. We can see the amount of keratinized tissues, we can plan for certain things, we can analyze the different gingival heights, we can go back and review our occlusion planes, and we can review decay on the teeth, and there's a lot more information that we get from clinical pictures. So a good set of clinical pictures, good investment is a camera, mirrors, retractors. I also would like to see a full panoramic x-ray. It's a lot different, a panoramic x-ray, than a panoramic rendering of a 3D x-ray. Some people take a CBCT and render a panoramic from that image. But the focal trough that we get on a panoramic machine, on a panoramic x-ray, is a lot bigger than the focal trough that we get on a CBCT rendering. We can see the quality of the bone much better on a panoramic image, and we get an overall view of what's happening with the patient. For example, on the third molars on this side, right? The impacted third molar and how that's going to affect our treatment planning and the quality of the bone. Now, for reasons that we cannot go into right now for the sake of time and for this discussion, I cannot express this in detail, but the quality of the bone, of the remaining bone, we can evaluate it much better on a periapical x-ray than on a CBCT. A CBCT image really does not give us the quality of bone. All the densities and different Hounsfield units that we get on a CBCT are meaningless because they are only used in comparison to the adjacent areas. A intraoral and panoramic really gives us a much better quality of the bone, the trabeculation, and the different densities that we find. Also, we see in much more detail how those teeth are, the periodontal ligament space. So I still like the intraoral periapical x-rays as part of my diagnosis and treatment planning. One of the downfalls of guided surgery is that we cannot evaluate properly the quality of the bone when we're drilling. Going through the guide kind of numbs up our feeling. It dampens our feeling of the bone. When we drill directly on the bone, then we can get a better feeling. So we need all the information we can gather, especially if we're going to do the procedure guided. We do require a great CBCT x-ray, a full image, complete arches that show the sinuses and adjacent structures, and we use this to gather all the information that we need from the bone on a three-dimensional aspect. We need intraoral 3D scans of the teeth with a lot of soft tissue. If we do not have enough soft tissue in our scan, or we're not able to gather a good scan with plenty of soft tissue, then we must use an analog method of capturing impressions, like with Alginate or PVSs, and then we can digitize those impressions. But we must have some STL files with good amount of soft tissue. And we must capture the patient's occlusion correctly. If we don't gather this, if we don't acquire a good occlusion of the patient in our records, then everything goes wrong from there. So plenty of soft tissue and in good occlusion. Now, the second step that we need to do after we gather these preliminary records is we need to analyze the vertical dimension of occlusion and determine if we have to raise the VDO of the patient. If we have angular cheilosis and if we have contracture of the muscles, the severe wear on the teeth, collapse of the bite, because we do have the ability to raise our vertical dimension in the articulator, in a virtual articulator, and perform a virtual wax up before we proceed to the next step. So we need to determine the correct vertical dimension of occlusion. After we have our records and a scan and an STL, we're going to correlate, we're going to import our STL model into our CVCT, and we're going to correlate the image of the teeth and the gums with the bone of the patient. And this is done in the Blue Sky Bio software. I like to use this Blue Sky program. It's an excellent, excellent program. Then we have to correlate the teeth with the face of the patient. So we have correlated now the teeth and the gums to the bone. Now we have to correlate the teeth and the gums to the face. And this is done over the pictures of the patient. There are several facial scanners out there. In my opinion, they're still not cost effective. And the quality of the avatar and the image that you get is still not much better than what you get in your simple exocad program. So I do this in exocad where I correlate the STL files, I bring them in and I correlate them to my patient's face. Because we have to determine if we are going to need any amount of bone reduction, right? And if we're going to change the teeth, we have to determine if we're going to move the midline of the patient, if the midline is okay, right? The vertical dimension is okay. But in these two cases, it's completely different treatment plan. In one, we don't have to do any bone reduction. In the other one, on the left one, we have to do significant amount of bone reduction to hide our margin. And we have to correlate that with the face, and we have to determine if we're going to do the bone reduction. So based on that, we can import our model into another software called Mesh Mixer. And we do what's called a plane cut. And it's simple. We just make a cut where we had determined that the that the bone reduction is going to be performed. And once we do that, we can now know, because that model was in the right correlation with the lower model, we can know if we have enough restorative space vertically, and when we correlate it to our patient's face, we're going to see if that bone reduction was sufficient or not. But we're also going to take this bone reduction model and we're going to import it into our Blue Sky Bio software, and it's going to have the same coordinates as our original model that we have correlated, because it's important to know if the plane cut that we're proposing on the model is feasible in the mouth. In this case, we see that that plane cut is very, very close to the maxillary sinus. And we see that there's some radiopacity in the sinus. This is level field here, so this is probably some fluid filled radiopacity here. But we're not going into our maxillary sinus. We see where our plane cut is. Now, if we go into the sinus, then there's other issues to consider. We also want to know if anteriorly, in the anterior section, we have enough height of bone for a restoration after we do the plane cut. So it's important to correlate that plane cut with our bone of the patient. Now that we have the plane cut that we have done, right, we're going to do our diagnostic wax up, our smile design over the patient's face and on that plane cut model, that bone reduction model. We can choose from an enormous variety of teeth. That's personal preference, what your patient's desires are, and what your personal preferences are. And we can do our wax up and actually provide like a preview of how that is going to look on our patient's mouth. Now, this doesn't look exactly natural, but it gives us a clear picture of how much tooth we're going to show, where the lip position is, where the midline is, how wide our buccal corridors are. So we gather a lot of information from this smile design. And once we have that and we tweak the right position of the teeth, we make our digital wax up using exocut. Now this is what's going to become our provisional restoration. That wax up we can export now out of our exocut software, and we can import it into our CBCT. These models are always going in and out with the same correlation. So once we bring in the wax up, it knows exactly where it was, correlating it to the other models. So now we have our proposed teeth position in relation to the bone of the patient. And that is what we need to do to start planning our implant position. Now the location of the implants and the size and the style of the implants, that is the responsibility of the dentist to plan that. Okay, this is not the responsibility of the lab. The dentist has to still spend the time reviewing the images in 360 degrees, approving the proposed position and planning of those implants. And what we can do now in this Blue Sky software is very easily we can plan for our implants, and we can select abutments that correct the angulation if we're going to use multi-unit abutments, so that we can see exactly how our implants are exiting through our prosthesis to know that we have the correct location of our implants. We can also see over our bone reduction model where those implants are going to come out related to the soft tissue of the patient, right? If an implant is exiting too far facially, we know that we may have to make our incision line a little bit farther to the palate so that we can slide that graft and give more keratinized tissue. So a lot of information is gathered from these steps. After we have selected our implant positions, we're going to select our pin guides, the fixating pins. We're going to fixate our guides to the bone with pins. So we have to select the location of those pins so that it doesn't interfere with our implants. And then we can create our pin guides. I don't particularly like the guides that go directly into the bone, because when we separate the bone in the x-ray, it has a lot of variability. So not necessarily a bone guide, a bone supported guide is going to be accurate. That's why I like to do my guides as much tooth retained first as possible and as much soft tissue retained as possible, in this case from the palate, so that we know that we can drill those pins and it's going to be accurate from the beginning. So before we extract the teeth, I like to do my pins. And we have to have windows to measure and to see that our guides are properly fitted. So this is the design of my pin guide. And then after we extract the teeth, we're going to do our surgical guide. This is going to be placed after we extract the teeth. So first we're going to index our guide to the bone with the pins, and then we can put our guide, surgical guide, to drill for our implants. And we also create our bone reduction guide, which is nothing else than our surgical guide that is pinned to the bone with a plane cut in the model like what we've made before where we planned our teeth. So this is going to become our bone reduction guide. And we go to our printer and we print our models. I like to use the Sprint Ray. This is the older version. This is a Sprint Ray 95. Now I have a 95S and I love it. But we can use it to print our bone reduction guide, our pin guide, our surgical guide. We also can print, and now we have a material that's very strong and it's designed for long-term use. We can print it in the material called Onyx Tough 2. And in this particular case, I have attached my pins, my guided pins, my indexing pins to my PMMA, so I have a reference of how to position that in the mouth. We can also mill our provisionals. I'm liking the PMMA printed provisionals a lot better these days. It's easier to print than to mill. And we are ready for guided surgery. If we have planned everything accordingly, our planning stage phase would be like this. Right? This is my daughter at the New York Museum of Arts, imitating the back picture. If we didn't plan everything correctly, this is the phase that we're going to have during our surgery. So hopefully this is the phase before the surgery in the planning stages and not during. If we planned everything correctly, we can go to the patient and try in our pin guide, right? Because everything is going to depend that this guide fits. So if you want to bring the patient a couple of days before, try your pin guide, make sure that it's fitting, fine. If not, you can try it in the same day. Now, if it doesn't fit and your patient's scheduled for the surgery already, you have to decide whether you're going to freehand your surgery or you're going to postpone, right? It's very, very rarely the case that it does not go accordingly, but if you want until you get used to these procedures, you may want to verify this step before the surgery. But we try in the pin guide, make sure that it fits. Then we proceed to elevate a buccal flap only, and we make a long flap. The longer we make the flap, the more elasticity the flap has, and the easier it is for us to reflect that flap high up. And we need to reflect that very high because we're going to have to do bone reduction, and we're going to have to place our pins. So we only raise a buccal flap. We keep the palate because that's going to allow us for some support of our guide. Now we put our pin guide in, and we make the osteotomy for our pins depending on the pin system that we're using. We use the sleeves according to our pins, and we just do the osteotomy with this guide as indicated. Once we have that osteotomy, like you see here and here, this particular guide had a tripod kind of stability. It has the two pins here and one on the palate. But after I had drilled my pins on the buccal, then we can proceed to raise a full flap, and this is the reflected palatal flap, so that we can have access to the bone. In this case, this patient did not need bone reduction for the sake of aesthetics and to hide the margin or for the allow restorative room, but we needed to level this bone to eliminate these thin parts of the bone and to flatten it for better aesthetic, better cleansability for hygiene of the restoration. In case we're doing bone reduction, then we have our bone reduction guide that we had made as our plain cut. We pin our guide to the bone, and it's as simple as trimming off the excess bone from our bone reduction. This could be done with rongeurs, or this could be done with this surgical burrs or acrylic burrs at high speed with plenty of irrigation. Now we knew that we were going to get close to the sinus. Here is the sinus that you can see on the right image, but it's not a problem. It's not perforated, and there's no issues with that at all. But notice how nice we have leveled off that bone according to our guide. After the bone is leveled, we proceed to pin our surgical guide. So instead of stacking the guides, a much simpler and cost-effective option for me is to take the pins in and out and switch guides. It's really a simple procedure. Even if you're pinning, stacking guides, you're going to have to pin those in and out. So I really don't see an advantage over the stackable guides. And now we can start drilling our osteotomy for our implants. And we can use any system. In this case, we're using a key system. We see the access to the bone, and the assistant can irrigate with a monoject needle, or we can use a fully guided system, right, keyless, where we go completely to length and there's no keys for our osteotomy. So whatever system we use, this is as simple as the osteotomy for an implant case needs to be with our guided protocol. And we're going to use the sequence of your particular kit, guided kit, and you're going to follow their recommendations. But that's as simple as it gets. Then we're going to proceed to the guided placement. We can actually pick up our implants with our handpiece and place our implants through the guide, okay? Going completely into length. So fully guided means that we're going in the direction and the depth provided by our guide, but also that we're going to time our implant properly. The timing is the rotation of our implant. When we're talking about guided angled abutments, a 30-degree angled abutment, especially like in the posterior areas, if you have your guide a little bit rotated, your implant is going to make a big difference on how that implant is going to exit through the bone. So most systems allow us to index our guides. In this case, the two parallel sides are lined up. That means that our implants are properly lined up. And if that is the case, then our multi-unit abutments that we're going to place are going to be in the right position for those cylinders to be parallel and to exit the prosthesis in the exact way that we had planned. We're going to torque our multi-unit abutments, usually to 35 newtons, and then we're going to place our temporary titanium cylinders. Next, we have our prosthesis that's been indexed to the bone so that we know in space that our occlusal plane is going to be correct and that our occlusion is going to be correct, because all this was meticulously planned in our software. We have to protect the bone, so either we put a silicone matrix in between the prosthesis and the bone, or in this case I had put some Teflon material to prevent the pickup material from attaching to the bone. In this case, we're picking the prosthesis up with a self-cured pink composite called Eufy Hard by Voco. I absolutely love it. You do want to make sure that there's no material that's going to go in the holes of these tie cylinders. Otherwise, you're going to have a very difficult time removing the prosthesis from the mouth. Now that we have picked up our tie cylinders, we take our prosthesis to the lab where we're going to finish characterizing it and we're going to polish our prosthesis. We want to have an underside that's polished, glazed, and it has the right convex surfaces to allow for proper oral hygiene. So the design of our prosthesis needs to be already established from this part. Now, while we are finishing the prosthesis in the lab, we're going to place the digital impression posts over our multi-unit abutments. I like to place these abutments and suture. They will help me suture the flap in place. It's much easier to suture when you have these abutments in place, especially when you're suturing a mandible. Once we place our digital scan post, while the assistant is finishing up our prosthesis, we are taking a final scan, a digital scan of our abutments in place, of our scan abutments in place. And we have a lot of reference points here with the sutures, and we have a lot of anatomy on the palate and soft tissue that we have captured. That will make it easy for us to correlate models. After that, we secure our provisional in place and we close the access holes with temporary material. I like to use the PVS material that I use as my gingival mask, as my pink soft gingival mask. Some people use light body material that you inject there, and it's very easy to flick that in and out of your prosthesis to take it in and out. And we verified the occlusion of the patient, right? This is our sutures underneath here. Our prosthesis is in place. Very important that we take an x-ray at this point and we correlate that our implants, our multi-unit abutments, and our prosthesis are all seating correctly. If that is the case, then we proceed to take a scan of the upper jaw with the prosthesis in place. We take the lower jaw and we take a bite. Okay, and we have to have a lot of soft tissue again in this scan because that is exactly how we're going to correlate both images. We need similarity of points. We need to be able to tell the system which point correlates to where. Most systems now have very easy ways of correlating those, and they do it by themselves. But in case we have to manually do it, we can tell the machine this point on the left is this same point on the right, this point on the left is this point on the right, this point here is this point here. That's why we need a lot of soft tissue. And if we've done it correctly, the system can merge the two models, overlap the two models, and now we have our record of our new prosthesis or smile design and occlusion of the patient with our digital scan post and the soft tissue and the correct bite. The reason for this is that everyone has a plan until they get punched in the mouth, like Mike Tyson says. My goal is that a patient comes in the day of the surgery. I see them 2 weeks later to remove sutures and make sure that everything's okay. And after that, I will see them about 3 or 4 months later. My goal is that the patient remains with the prosthesis in the mouth for the 4 months. But sometimes things don't happen, right? You get punched in the mouth. The patient breaks the prosthesis, or they don't like it, or something happens. And if you did not take the appropriate records the day of the surgery, it's much harder to go back and try to recreate a prosthesis for the patient. You're going to have to go back to bite blocks and make a new smile design and so on and so forth. And if we did things correctly, this is our result. The patient comes in, the pre-op picture. This is 2 weeks after with the provisional restoration. And this is the same patient with the same smile, tentative smile, right? When we tell them big smile, now they're showing a little bit more teeth. And when we tell them a good joke, they show us the gums. And if we did not plan for this stage and we didn't do enough bone reduction, we're going to see the interface here where the patient smiles and the patient's not going to be happy. So we got to plan things accordingly to be able to execute things accordingly. Now, sometime later, and this is a personal choice also, how long you're going to wait for your prosthesis. In this case, it was 12 weeks post-op, patient comes in, right, with the same prosthesis that we placed the day of the surgery. And same occlusion, it's been stable, nothing has broken, patient doesn't have any muscle symptoms, any joint symptoms, so we know that our vertical dimension's okay, we know that our occlusal scheme is correct. We remove the prosthesis and we place our impression post and we take a new scan of the soft tissues. Now, while we're taking the new scan, I'm going to take the patient's prosthesis and attach lab analogs into that prosthesis. This is absolutely a very important step because I'm going to pour that in stone. Notice that you're going to leave some room between the prosthesis and the stone to be able to later see your final prosthesis. But this is going to become your verification jig, taking the day of the impression, the final impression. So no need to go back and forth with the lab, no need to cut it and reset it. This is what's going to become our verification jig. And those implants are in absolutely the most perfect and accurate position possible. The patient had that prosthesis for the 4 months, those implants healed in that position, and everything's very stable. That's why it's very important to verify the seating of your components the first day of the surgery when you take that x-ray. Because if things were not accurate on that day, you're not gonna be able to produce a verification jig. But this is the reason why I do not need photogrammetry, because I do have a verification jig. So with my digital impressions, right, I have my upper, new upper, with the prosthesis, new upper without the prosthesis and the verification on the digital scan post. I have my lower teeth and I have my occlusion. So I just need to correlate both models. In this case, we're correlating them in Blue Sky Bio, and this is what I'm telling you, that we need a lot of soft tissue so that we can correlate and we can tell the software, okay, which points correspond to which points. If we don't have the soft tissue in this part, we're not going to be able to correlate our models. And so once that we correlate our models, we have a perfect record of the occlusion of the patient, the upper arch, the lower arch, and our prosthesis. So we have a record of our vertical dimension of the teeth that the patient had, and if the patient liked those teeth, we can follow up that same scheme on our final design. So we're going to use the provisional as a guide for our final design. And we can do it as elaborate and as intricate as we want. In this case, I decided to do a monolithic zirconium framework, and the 4 anterior teeth, I decided to make them individual crowns, because it gives us the ability to make them look more individualized. And we can make them out of the same material. We can do a zirconium framework with individual zirconium crowns, or we can do zirconium framework with Emax crowns, which is even more beautiful. So in this particular case, it was a monolithic zirconium structure with the 4 individual crowns. And then we go to the lab. The 4 crowns are not cemented, they're fused to the framework. And we fuse them just by placing glaze on our crowns and putting it back in the zirconium oven. Now, I love the Mio porcelain by Jensen, and we can characterize our prosthesis with this porcelain and make it look absolutely gorgeous. So this is our design with the 4 front crowns that were single crowns and have been fused to our framework, and we have finished our restoration with the Mio porcelain, Mio stains. There is nothing that the tissue loves more than well-polished zirconium. Nothing comes even close. Now, over our model with our verification jig is where I'm going to try in my tie bases and make sure that the fit is completely passive. We're going to do the Sheffield's test and screw one of the screws in, make sure that the prosthesis is not rocking and that everything is smooth. And once we get that, then we can bond our tie bases in place. And I like to use the Reliax from 3M to bond it, and I use the Circumbrite from Bisco to prime my zirconium for bonding. So I do bond tie bases. Nowadays, we're tending to go over more direct to multi-unit component with the different screws. You can do it, but it's a little bit trickier. I still like the flexibility of the tie bases. And these are the tie bases bonded over our well-polished zirconium understructure. Here is our prosthesis in the mouth, and this is monolithic zirconium in the back with individual zirconium crowns that have been fused to the framework, so they look absolutely more individualized. And look at the design of our soft tissue that allows for hygiene, right? Our occlusion, our fit that we verified on our x-rays. Then we proceed to torque our prosthesis in mouth to 15 newtons. Those are tiny little screws. By hand, we torque to 10 to 15, but make sure that you don't over torque these screws. We place Teflon inside of our access holes, and then I like to seal them off with Omnichroma composite. You can almost invisible where we're sealing those access holes. And this is our restoration characterized with Mio porcelain.
Thank you very much. They look great. They look wonderful.
How has the process been for you?
It was smooth. No pain. No little swelling. Very smooth. Very happy.
What have you been able to eat now that you couldn't eat before?
Oh, pork chops, steak, potato chips, just about anything and everything.
So that is what we're aiming for. Very smooth. Thank you.